My name is April.
Jessica.
I'm Timothy.
And our presentation is on tuberculosis. So tuberculosis is a chronic, recurrent infectious disease that is caused by the bacterium mycobacteria, or the bacterium mycobacterium tuberculosis. It's a slow-growing, rod-shaped bacterium that has a waxy outer capsule, and that helps it survive from being destroyed. TB is the transmission of TB occurs through small airborne droplets called droplet nuclei, and they're produced when an infected person with TB sneezes, speaks, coughs, or sings. The droplets remain, these droplets can remain in the air, suspended in air for several hours. So it's easy, if you're in close range of someone, or even just walking by and breathing that in, you could, several hours later, could still contract the TB bacterium. During the time, the vulnerable host inhales a droplet, and each droplet can contain anywhere from 1 to 3 bacteria. Once inhaled, the droplet nuclei bypasses normal defenses of the respiratory tract and implants in the alveolus or respiratory bronchiole, usually in the upper lobe of the lung. Because the mycobacterium is an obligate aerobe, meaning that it requires oxygen to survive, the alveolus is usually the preferred target for the mycobacterium, just because it has a high concentration of oxygen. So once inside, the inflammatory response, the first responders, the neutrophils and macrophages come in to try to engulf. They do engulf and isolate the tuberculosis. They're unable to destroy the tuberculosis though. So what happens is once the neutrophils and macrophages engulf the tuberculosis, it starts to form a granuloma called a tubercle. So inside the tubercle, the tissue starts to die, and it has a cheese-like appearance, and that process is known as caseation necrosis. So if the bacterium remains inside of encapsulated inside the granuloma, the person is said to have latent or inactive TB. And this picture just shows some of the lesions of the granuloma. If the granuloma ruptures, the bacteria is released and can become active. Once outside of the granuloma, the bacteria can enter the bloodstream, where it can affect other parts of the body, such as the kidneys, bones, brain, spinal cord, and genitalia. Do you guys want to watch the video? It's online. The video is posted on Moodle. You can see it, but it just shows the process. Some of the risk factors for tuberculosis are tight living quarters, either in long-term care facilities, in prisons, colleges. Other risk factors are those that live below or at poverty level because they lack healthcare access, immigrants that migrate from areas of high prevalence of tuberculosis, and here are some of the countries listed here that are at a higher risk for tuberculosis. Also, those that are at high risk are immune compromised, such as HIV and AIDS, those that have received an organ transplant, chronic renal failure, those taking immunosuppressants, drug users, especially those that are alcoholics, and children under 5 because their immune system is not fully developed.
Okay, so signs and symptoms with TB. Initially, you're going to get these really non-specific, kind of generic signs and symptoms like the fatigue, weight loss, which is due to their loss of appetite, night sweats, and a low-grade fever. And then the more specific symptoms that we typically think about with TB are the persistent cough that can last for longer than 3 weeks, chest pain, and bloody sputum. So you guys are probably all really familiar with the skin test.
This is also called the intradermal PPD or the Mantoux test. So 3 different names for the same thing. Do you guys remember what the name of that syringe is by any chance? That's the kind of injection that it is. So they use the tuberculin syringe, to give you the test, and they inject the 1 milliliter of this purified protein derivative from tuberculin into your upper forearm, and they do it at a 15-degree angle, so it's almost parallel with your skin. And so you can see this is called a wheel, and that's what will happen once the medication is injected into the skin. And that is the site that they're going to measure within 48 to 72 hours to see if it's hardened, if it's still swollen and raised like that. There might be some redness, but you're actually not measuring any of the redness. And there's also a quantiferon test. That's okay. That's the one that we think of as the blood test, and it just measures a component of our cell-mediated immune response. And I thought it was kind of interesting the way that they do it. They have it incubate overnight, basically, so your blood's in a little tube, also with the PPD derivative, and you can get the results the next day. And these are your results of the PPD skin test. If the wheel is greater than 15 millimeters, and these are all measured in millimeters, then that's a positive for everyone across the board. If it measures 10 to 15 millimeters, it's positive for certain populations with those risk factors we talked about earlier, people that live in close quarters or IV drug users. Someone with a 5 to 9 millimeter measurement are positive if they have HIV or they're immunocompromised, for example. And if it's less than 5 millimeters, then that means it's negative all around, although it's not 100%, it doesn't 100% rule out infection. There could be some latent TB that's hiding. Next one. So if you do have a positive skin test, there's additional diagnostics to confirm or deny the results. There's the sputum culture and smear. With the culture, they're looking to see if the tuberculosis will grow. The smear, they're going to look under the microscope to see. They actually add a chemical to it that, like, denatures the color, and so if there is TB, it just leaves like a red color, so that's how that is determined. And a nurse can get those. Respiratory can also take those samples. Another common test that we'll see is the chest x-ray, and a lot of times those are looking for dense lesions that, as April said, a lot of times it'll be in the upper apex portion of the lungs. And the polymerase chain reaction is a rapid detection of DNA from tuberculosis. And that's a really cheap and fast test that they like to use. Next slide. So there's also tests that are done to assess a patient's baseline data before they start medication treatment for TB. It just helps monitor them for any reactions they might have, because some of these drugs cause really adverse effects, such as hepatotoxicity with the isoniazid, optic neuritis with ethambutol, and something we learned in 111, the ototoxicity with streptomycin. Timothy tell you more about management and treatment.
Okay. So talked a little bit about tuberculosis. Now you get to hear what they do for it. So management and treatment. You're going to use antimicrobial drugs to prevent and treat infections, ensure disease is non-communicable to the public, reduce symptoms of disease, and achieve cure in the shortest possible time. One thing they do for immunocompromised individuals is prophylactic treatment, which is a 6 to 12 month dose of the antimicrobial isoniazid, and that's just to prevent the infection of those higher risk individuals. You can go to the next slide. Okay, so treatment for active disease. Total treatment time is 180 days, or about 6 months. The first 2 months consists of these 4 different antimicrobial drugs. You might wonder why they have to have 4 different. It's because Mycobacterium tuberculosis is a very intelligent little bacteria, and it knows how to mutate and make itself more resistant very quickly. So isoniazid, that inhibits mycobacterial cell wall synthesis. The rifampin inhibits RNA synthesis inside the susceptible host. And then the pyrazinamide, it lowers the environmental pH. The tuberculosis bacteria likes a higher acidity level, so if you decrease the pH, or excuse me, I might have that opposite. It likes a higher level pH. So if you decrease it, it makes it harder for it to survive there. And the ethambutol inhibits the growth of the mycobacterial cells. Following the first 2 months, you need an additional 4-month treatment with isoniazid and rifampin. Nursing considerations primarily focuses on infection control and compliance with prescribed treatment. You have to educate your clients, promote effective therapeutic management. Especially like with your homeless or lower economic groups, it's going to be harder to find those people and follow up with them to make sure that they are taking their treatment antibiotics like they're supposed to. Reduce risk for infection. Respiratory precautions are vital in preventing the spread of the disease to vulnerable populations and healthcare workers. So that kind of goes into evidence-based practice. From what I read in our article and from the CDC, the best thing we can do evidence-based as nurses is prevent the disease. We're the ones who put in the PPDs. We're also the ones who read the PPDs. So making sure that we're doing that in the time frame that it's supposed to be is vital to preventing it. Another thing for treating patients with active tuberculosis and preventing the spread is with airborne precautions, which in your little handout, the second page gives you a great detail on what consists of airborne precautions. One of the things we use in a lot of hospitals is negative pressure rooms. So that means that in this room there's air constantly being pulled out and away from clinical areas, and then air is just passively flowing into the room. So no contaminated air gets out into the other clinical areas. We have some masks for you guys to look at. With airborne precaution, you want your client to wear a surgical mask to prevent droplets getting away from them. And then for staff, you want to wear an N95 mask. The reason you wear the N95 as opposed to a surgical mask is it has a thicker filter with smaller pores, which prevents most of the bacteria from getting through. These masks have to be fitted from person to person because they have to have a tight fit, otherwise they're not effective. Also, one thing I read is that if you have a nurse who has like a lot of thick facial hair, the mask is not going to protect them, so that would not be a nurse you would want to take care of a tuberculosis patient. Evidence-based practice isn't worth it when it comes to TB. One thing I have for you in this handout is a little chart that you can look at. And if you look at it, around the 80s and 90s, there was an increase in cases of tuberculosis. Now, can anybody think of why that might be?
HIV epidemic.
Yeah, HIV epidemic was on the rise, and then also there was a sudden influx of immigration at that time. So we had a lot of people coming in from other countries. We were dealing with the HIV/AIDS epidemic. So this is where some of your evidence-based practice starts to come in. Around that time and throughout the 90s, the U.S. decided they were going to start testing all immigrants for TB. They were also going to start testing individuals in long-term care facilities, prisons. A lot of summer camps test for TB before kids go to them. So any area that is going to have a lot of people habitating together. And what you can see is after they did that, the rates slowly started to decline from about 25,000 to now about 9,000 new cases a year. So that is some evidence-based practice that was working that you can see right there. One of the questions we were asked is there enough research to validate change in nursing practice? And is more research needed to validate change in nursing practice? Well, I think you can see that just from this little diagram right here that obviously, you know, those changes that have been made, nurses administering PPDs, maintaining airborne precautions has helped to decrease the new cases of tuberculosis. That being said though, we still have about 9,000 new cases a year, which costs the U.S. over $460 million a year in healthcare costs. So I don't think we necessarily need to make changes on what we're doing, but I certainly think we need to promote airborne precautions and infection prevention better than we do. Working in long-term care, I know I see nurses plant PPDs and then never look back at them again, never check them again, or they just chart that they put in the PPD and it never happened. So little things like that, we need to better promote how nurses are supposed to prevent tuberculosis. One last little thing I have for you guys is on the very back of your handout, I made you a nice little 10-step to help study from. It's basically a breakdown of our PowerPoint. It might be a little bit easier to follow. So I think we're going to do this by the hand-raising system because we have some bigger prizes, so just fight it out.
All right, number one.
Somebody's already ready to answer.
More precautions. And the answer is
Airborne precautions.
very good. Thank you, Lily. Okay, the healthcare provider is evaluating the tuberculin skin test for a patient who has a diagnosis of human immunodeficiency virus. The skin test is positive in the area of induration. That's also the wheel. Is at least how many millimeters? Easy.
What was the answer? D. A.
Not good. Not good.
You got another question?
Yep. What would be a positive PPD skin test result across the board for everybody?
15.
Very good. 15 what?
Millimeter.
Thank you.